perspective of this. Oh, and as y'all know, this meeting is being recorded.
Yeah, thanks, Melanie. So yeah, Dr. Zeller and I are, in addition to construction, since you guys have your local experts, we are going to also talk about what goes into stocking the unit and really getting it ready, and then answer some anti-ligature questions. So thank you for those who submitted those questions. It's really, really helpful. I'm actually going to start by answering the question on medication and what goes into your Pyxis or Omnicell. So I'll hand it over to Dr. Zeller to kick it off with the first slide.
Oh, thanks, Kimberly. Yeah, so obviously medications are going to be a big part of your treatment plan with the majority of your patients. And so having a stock in your Pyxis is equally important. One of the things I think that's really nice to know is that the great majority of the medications that you will probably be using in an EmPATH unit are already on generic status, so they will be relatively inexpensive. And I know that's always something nice to be able to tell your pharmacy director and your CFO that you're really only going to be stocking. Just about everything is going to be a generic medication. Which is really nice. You don't need to be using anything that's brand new and costs $275 a pill or anything like that. So here's a list of the kind of meds that you probably are going to want to have in your Pyxis. And the ones that you're going to want to have most accessible is your antipsychotics. The most common medication that you're going to be using that's something that can actually have a profound effect on individuals in less than 24 hours is going to be antipsychotics. And then there's two intramuscular medications that we strongly recommend that you have, actually both if possible, and that they often can be just used by themselves as a treatment for agitation. They're FDA approved for the treatment of agitation. That's IM olanzapine and IM ziprasidone. And that you would also want to have oral versions of all the medications that you're seeing on this list. If you have people at your program who are saying, hey, we're going to be using a lot of haloperidol, you may want to have an individual chat with us about why that's probably not a good idea and that you really should be looking more at the second generation antipsychotics. And Haldol should only be a fourth line option, if at all. The other medications that's really going to be important that you're going to be using on a daily basis is your benzodiazepines, especially lorazepam, also known as Ativan. You want to have that both in a parenteral form and an oral form. Something important to remember is that the oral form has the same time of onset as the injectable form. So there's really no reason that you have to give a shot unless you've got somebody who's refusing meds and it's an emergency situation. These other meds are going to be useful. You can be helpful for treating things like alcohol withdrawal, people who might need some sedation, people who want help with sleep. The other medications on here are going to be more for if you're continuing people on home medications and they don't have to happen to have those meds with them. There may be some use to start mood stabilizers in the EmPATH unit. Some people may want to start antidepressants in the EmPATH unit, but antidepressants really aren't going to work for several weeks. So that would just be a decision like usually it's going to be restarting home meds, or you may be having a conversation with the patient, decide that you're going to be starting these, but you're certainly not going to expect you're going to see a turnaround with starting an antidepressant in that unit. So mostly these are going to be for use where you're continuing home meds, or if you're initiating with the consent of a patient, you've got a good aftercare plan where they're going to have another provider who can give you those meds. Other than that, it's really just some basic kind of things that you're going to have, to just care for average ambulatory illnesses. You want to have albuterol puffer for people who come in with asthma so that we can have something for them if they start to have a mild attack of wheezing or what have you. Some pain meds and basically some other just straightforward meds. But very, very simple med list, very inexpensive because everything's generic. And if you have any questions on any of these or want some help in guiding your specific Pyxis for your EmPATH unit, please feel free to reach out. We're happy to meet with you at any time. Kimberly?
Yeah, so the other question along that we received in regards to building and preparing for the unit is what exactly do we need to order? What goes into stocking the unit? So we've created a list. I'm not going to go line by line. We have a one pager that we can send out for everybody to review and have on hand. But just to get you starting to think about what you're going to stock in the various rooms, we really like to think about it by location. So in your intake area, it's really about some office supplies that, wow, really, what are you going to do to welcome that patient? You will want to have the whole, the medical supplies available in intake in case you need to take blood pressures, you know, the cleaning supplies, allergy bans. This is often a time when we re-register, re-ban patients if they've come over from the emergency departments. And then we'll go into the milieu. So of course, the milieu, this is where your recliners are going to be. There's a lot of great resources on ordering these that are ligature resistant or as close to as possible with that line of sight. Just as a friendly reminder, the loungers or recliners are typically, well, it'll be your hardest piece of equipment to get. So start looking at those, pricing them out and submitting your orders. We've seen folks wait up to 12 weeks to get those delivered. So you definitely don't want to wait for the last minute to order those. You'll want a weighted table, an area for socializing, and then some other basic supplies. Next, we're going to go into the calming room. So the calming rooms are actually pretty sterile. Depending on the number of calming rooms you have, you could have one with a simple beanbag, something really ligature resistant, comfortable for someone to go in. But if you're going to only have one room, this is the area where you'll want to have that restraint bed. You don't want it to look like it's ready to restrain anybody. You don't want anybody to be frightened by it. So it's typically just made up like a regular bed, but access to your restraints in the event you need them for that 1 in 1,000 patient. Your consult room is also pretty simple: desk, computer, chairs to see the patient. The nourishment area, again, the nourishment area is intended to be self-serve for your patients. So whatever they can easily go and access, maybe behind the milieu doors, you'll have access to a microwave to prepare a hot meal as needed. But here's some samples of what we typically see get stocked in the nourishment area for that self-serve access. And finally, we're going to answer some of the questions that we received about life and safety, and then we'll hand it over to your local experts. So I'm going to hand it over to Dr. Zeller to talk about the square footage requirements.
So, yeah, thank you. I don't know how many of you have been talking with the architects, and they probably are already familiar with what the FGI code is on the national level, and that there's in EmPATH units, there's intended to be 80 square foot per patient. Now, that's not 80 square feet per recliner, which sometimes people could kind of mix them up and think that they need to have this 80 square foot space around each recliner. No, that's the total amount of space you have for each patient. And so maybe there's 36 square feet around each recliner, and that would give you enough room for social distancing and whatever you might need, at least 3 feet between each chair. And then the rest of the space is for those other things, kind of like Kimberly was describing, the tables for activities and for board games and cards and things like that, or where people can sit to eat. Make sure that you have enough space where somebody who might want to pace or walk around can do so without being disruptive or causing problems. We know that a lot of our patients, when they're in a very acute stage, tend to do better by pacing about. And that's something they can never do in an emergency department, of course, but we would really like them to be able to do it on an EmPATH unit. Again, just another one of these things that helps people relax and minimizes the chances that they're going to get agitated and aggressive or violent. One of the reasons that we only have, usually average 1 or 2 out of every 1,000 patients needs restraints is because of that feeling of roominess, the feeling that you're not claustrophobic, that you're not being imprisoned. The calming room does need to be 100 square feet as a minimum with a restraint bed. And what you want in the design of that, if you are going to use that one restraint bed for those once in a blue moon restraints, is that there has to be enough space that you can walk around the bed and that somebody can sit behind it who's a sitter and is doing that one-to-one during the time people are in restraints. But the restraints, as Kimberly mentioned, should never be left on the bed and are only brought in once you've totally determined that somebody needs to go into restraints, and then you can attach them to the bed. Back to you, Kimberly.
So again, I mentioned earlier about the ligature safety. So it's really important. We want this unit to be as ligature resistant as possible. That's what helps decrease the number of sitters and allow you to have that line of sight. So some of the ligature fixtures should be everything from your bathroom doors, your shower features, your sinks, the knobs, all those things need to be the ligature or behavioral health equipped. Furniture and equipment, again, we talked about weighted furniture. You don't want anybody to be able to pick anything up and throw a big table or a big chair. So you'll want to order that weighted furniture. The windows, you'll need to take into consideration your windows, one for privacy, and two, can something be broken? So you'll want to look at the type of glass you're using. A nice tent on the lower half is always nice for the privacy. You don't want to tent the entire thing if you can avoid it. That way you still have some of that natural light coming through, which is always helpful for the milieu and the healing environment. We get asked a lot about bathrooms and are they kept locked or unlocked? So your bathrooms, you actually want to keep them locked the entire time, and your staff will want to be able to open them for the patient and know where the patient's in there. The patient can lock them once they are on the inside, but staff needs to know someone's in there and be doing those frequent checks. You know, someone's in there, it gets quiet for 3-5 minutes. Let's knock on the door, let's check. But they'll be going into the bathroom and it'll already be set up for safety. So there shouldn't be anything in the bathroom that they can harm themselves with. But keeping them locked avoids somebody leaving something in there, avoiding a risk of injury for you not knowing where your patients are at on the milieu.
It's other people from going into the bathroom when somebody's in there,
Yes.
which we certainly don't want to have happen. I have plenty of stories of people actually going in and joining somebody in the bathroom. So no time to share those today, though.
Now we're all intrigued and we want to know, maybe the next webinar. So the windows, again, I already went over this, tapered, tinted, and safe. We get asked a lot, how do we keep our staff safe in the unit? What do we do? So it is encouraged and recommended that you do have the security cameras, especially in any area that is out of line of sight. You'll want to be able to see those areas at all times. You need to prepare for an egress plan. So these units are locked. So what is your egress plan? How are the doors going to be released in the event of an emergency? Do you keep them locked and need a key? Or is it badge access? Are they delayed exits? So those are things you're going to want to put into policy and practice and plan. Panic alarms, strongly encouraged, even more so. Who do those alarms go to depending on the location of your units? Does it go to your local security? Does it go to your operator? And what is the plan in place when staff activate those panic alarms? We usually see these located on a couple of spots on the nurse's station as well as in the intake area. And then the more badge access you can do, the better. Nothing's worse for somebody to be carrying and fumbling with a whole key ring of multiple keys. So anytime you can put badge access on all these doors, your staff will greatly appreciate that. And it actually has a more cost savings in the long run because you're not rekeying things and losing keys and all those good things. Bathrooms, again, you can take a look here on the picture. Those are all those blue dots are things for you to think of. Where could someone potentially harm themselves, and how do you order and set these bathrooms up so they are within behavioral health standards? So the grab bars that are in the bathroom, those need to be totally enclosed so nobody can slip anything around it. Again, your sinks, you can see that faucet does not have the ability for anybody to tie anything around it. That glass is tapered, it's shattered. Somebody could not shatter that. The toilet bowls, the knobs in the shower head, those are all items that are ligature resistant. Phones, believe it or not, this question comes up a lot. What kind of phone do we need to have on the unit? Yes, patients need access to the phones. This is a big piece of the patient rights, but we see a lot of questions come in. Do I need to have a phone on a wall, old school dial out. We strongly recommend just get some cordless phones, have them on the unit. They're light, they're fairly inexpensive. If somebody wants to throw it and it shatters, that's all right. But it does allow the patients to have some privacy if they want to go sit in their recliner and make that phone call. This is a huge benefit and a nice item for the patients to have. Cell phones are kept off the units. They're put in those lockers. Of course, if somebody is adamant they need to get a phone number out of their cell phone, we'll just walk them to that location, allow them to get that phone number, write it down on a piece of paper, and then give them the cordless phone to utilize.
Yeah, one real quick thing on that, the main reason we don't want people having their cell phones on the unit is that they have the capacity to record and take photographs and video, and that's a huge violation of privacy in these units. We also don't want people accessing social media and other things like that. So it's only going to be a few hours there in EmPATH. I know it's hard to get away from the people's smartphones, but they should be able to do it, and that will help us treat what's going on in their crisis without any distractions.
The next item is about the lockers. So you will want to have an individual locker for each patient that comes in the unit. Typically, we see these located as part of the intake. It's an opportunity for you to reassess the patient's valuables, make sure you removed anything that's presents a risk, store their clothing. Ideally, we're storing their personal clothing and they're going to get in some more comfortable scrubs. Or we've recently seen some hospitals start to order some sweatpants and sweatshirts which look really nice. So if your intake area allows for the locker rooms flow-wise, that works really nice. It's not the end of the world, though, if your space doesn't allow to have the lockers in the intake. We've seen them in the milieu. We've seen them in other locations. They work really well, but they do need to be, again, if you're putting them on the milieu, ligature resistant, all the doors need to be locked and labeled and stored for the each person's individual belongings. I'm going to pause right there and give a chance to answer any questions. And if there are none, then I'll hand it over to the rest of the team.
Hey, Scott, Zane. I noticed there were no NSAIDs on your medicine list. Is there a reason for that?
I think that's probably just because of the list that we had. Yeah, I mean, it's fine if you want to have Motrin or something along those lines as well. I mean, I think with the Tylenol was kind of a proxy for you can have Tylenol, aspirin, ibuprofen.
Hey, this is Catherine at Lexington. What about long-acting injectables, or how do y'all manage that?
So long-acting injectables, the main thing to know about them is that they're really, really expensive. They're usually a couple $1,000s a dose. And unless you have a setup with insurance where they're going to pay for that dose for you, that's going to be difficult for you to administer. It's probably going to eclipse the entire reimbursement for your stay just to give one of those. They're really more intended to be given in clinics or outpatient clinics where it's much easier to bill for their utilization. What you can do, some of these LAIs do offer a first dose free if you are then connecting them to a specific provider who is going to be the ongoing LAI distributor. Those programs tend to come and go. If that's something that you would want to do, then you can do that. But again, realize that you are the equivalent of an emergency room for psych patients, and an LAI is a long-term decision that you would be making with a patient and their caregivers, if applicable. So it may not be something that really comes up very often. But if you do want to do that, you're going to need to figure out some kind of agreement so that your costs are covered.
Thank you.
Sure.
Kimberly, do you know if we've answered the questions that came in ahead of the session?
We did. We included them all except the financial questions in the presentation because we know we're going to be talking finances a little bit later, but all the questions were listed on the slides.
Okay. Fantastic. There were some great questions that came through ahead of the presentation. Does anyone else have any other questions for Dr. Zeller or for Kimberly on the Vituity side? Okay. All right. Well, let's turn it over to the Department of Public Health construction team. And I think that we've got let's see, Graham Cormick. I don't see him directly on the call, but anybody who we have from the Department of Public Health construction team.
Hello, hi, this is Collab. I'm
Collab.
from a construction team. I'm the new one here, so I'm understanding now. I guess Graham is maybe on the road or something, like on the way. So I think he might be in any minute. If not, I will try to answer whatever was the question.
Okay, that would be great. We can, let's try to switch it over to Charlene. I know that licensure is not required, certainly not within, obviously not within CON requirements any longer. But do you want to run through your process of really how relatively simple it is on the licensure side?
Yes, hey, this is Charlene. What I just want to recommend with we're going to talk about expediting the process once you get your approval from construction, and we usually follow construction after you get that approval. It would help us if you kind of contact me to let me know that you're getting ready to add this service, because what we can do then is kind of talk through how your service is going to look or how your department is going to look. And then we can go ahead and kind of tentatively get you on the calendar. So there will be no holdup, and we can kind of, because what we're looking at trying to expedite getting all getting your area open. And I can give you my contact information. I know Melanie has it. So that's about it for licensing. Do we have any questions?
Yes, licensing is definitely.
So sorry, Graham, all of us, but I think he got something with his speaker, but we can't hear him, but he can't hear us. So I just have to send you this because he just forwarded me this message. Hopefully you're gonna see that out.
All right, hang on one second. We are still trying to get our volume ready here, and then we'll be able to hear, the whole room will be able to hear.
So this is Zane again. Can we talk a little bit more in depth for a second about licensing? What, we're a very small ER, and we're just going to basically have a small portion of our emergency room laid out for EmPATH. What are we talking about in terms of specific licensing and things like that?
Right, this is Charlene again. Pretty much it will be based on, we'll probably get a lot of how your setup is from the notice of completion, because it'll kind of give us, what we need to look at. And on our end, what we will be looking at is kind of like your policies or procedures, how you plan to staff, and we may ask to kind of see how this flows in that process. But that's pretty much all of what we would look at. We would do a walkthrough, kind of make, looking at your medications and what you have. That's pretty much it as far as licensing, just the procedures, your walkthrough, and looking at what is listed on construction as far as how your areas, the area set up.
Okay. All right, so there's not specific licensing requirements that we need to make sure that we're addressing. I mean, because basically this is going to be a corner of our emergency room with an open area,
Right.
A control room, and a quiet room. So I mean, it's
Right.
not a freestanding building. There's not going to be any specific intake for this. They're going to come through our triage and through the ER, and then then they'll come over here to for further stabilization.
So what, if I
Correct.
could jump in real quick, which might be helpful, in a lot of states, they have licensed these under the general hospital license as observation units because they're really very analogous, almost identical conceptually to an emergency department observation unit.
Correct. Right. We see it as an extension of the emergency department. Correct.
Okay. All right. So I'm not aware of any specific guidelines and templates and check boxes and things we need to do for an ER observation area. Do you have that, and can you get that to us if we?
It really is not in the regulation. It's pretty much when we come in, if you've ever had us come in to look at an initial modification. I know some of the people on the line has had us come in. They kind of come in after look at those new areas. That's what it'll be pretty much like, just a walkthrough. Again, like I said, just looking at your procedures and just maybe how it flows, since it is an extension, how you flow a patient from here to here. And that's it. But there is no check boxes or any form that you need to fill out.
Okay.
I have a comment regarding guidelines for this type of units. Can you hear me? Hello?
Yes, we can hear you.
The FGI guidelines, they have a section for behavioral health crisis units on the outpatients. Guidance manual. And also there's a white paper on their website for behavioral health crisis units, which mentions the EmPATH units. I just wanted to say that comment.
Hey, this is Charlene. You know, MIDA is part of construction with public health, and I think Graham is trying to chime in. So he's dialing in.
And maybe you can just dial in on his phone.
I think that's what he's doing. Is he saying something? Hello, Graham? Hey, I have Graham on a phone in here, and if you have any specific questions, I think he can hear, and you should be able to hear him.
Yeah, can you all hear me?
Oh, yes, I did hear that. Maybe say a couple more words.
Yes.
Go ahead and say something else, Graham. I think everybody can hear you.
Hello, I'm Graham Cormack. I'm the Director of Health Facilities Construction.
Thank you, Graham, very much. We appreciate you being here. We were, I don't know how much you've been on this call, but we were hoping that you could talk about the EmPATH units and their construction and the process that you've reviewed with us over the past week or so.
Yeah, I've been on the call the whole time. A little frustrated with not being able to be heard, but that's okay. So you're asking me about the process of working with us. Is that correct?
Yes, when hospitals are looking at construction of their EmPATH units, whether they're in the facility or outside of the facility, could you talk about the process for what they need to do for with your office on the construction part?
Yes,
And the
I'd be happy
regulation
to.
under 6116 regulation.
First step is they need to get a licensed architect involved in the project, and it's specifically got to be a South Carolina licensed architect. The firm does not have to be based in the state of South Carolina, but we do require them to be a licensed South Carolina architect. The second step is to fill out a construction project information form. That provides us with a tracking number that we use all the way through the project. And it really helps us simplify things and be able to know where we are at any point in the process. And then the second thing would be we go through a series of schematic, design development, and construction plan reviews. Upon the completion of the plan reviews, we will then go into doing 3 inspections, an inspection, which sometimes may be waived if there's no construction being done in the walls, like no med gas or no piping. And then we would go into an above ceiling inspection. Prior to ceiling installation, the grid may be in place if it's got a grid, but typically these type of areas have a hard ceiling, so we want to see. And then we'll be in for a final inspection. After our final inspection and you've passed it, then we do a notice of completion, which then triggers licensing to come out.